Welcome everybody to the September 2024 National Urban League Health Equity Webinar Series. As most of you know, my name is Lydia. I'm the Vice President for Health Equity and Policy, and we do these webinars 10 times a year. We take the summers off because it's always very busy, and we use this as an opportunity to educate and to talk with our communities about issues surrounding health equity in African American and Black communities. And in particular, this focus of these health equity webinars have been on social determinants of health and ways in which improving the lives of the communities that we serve. And so I'm really excited today because this is a little bit of a different topic for us, but came out of a really interesting conversation. So I want to give some folks some background on this idea of clinical trials and having more African Americans and Black populations participate in clinical trials. And when we were thinking about this topic, there's lots of work that needs to be done around clinical trials and our participation. But we've been talking about this for a while. And what we also wanted to think about is not only just the idea of our folks participating in clinical trials, but also the whole life cycle or lifespan of drug development, from developing the drugs to clinical trials to access to care. And so that's why we broadened the scope of this webinar to talk about access to medication, because clinical trials is one aspect and it's an important aspect, and we're going to talk about it. We have esteemed folks here. The drug development is another aspect, but also once the drug has been, or the therapeutic has been approved, how do we make sure the people who need it get access to it? Right? And that's an important part in the lifespan of access to medications. It's not just making sure that represented in clinical trials, which is important, but it also means once the clinical trial is approved and the drug is approved, then how do communities that need it, that is going to be a life-saving therapeutic for them, get access to it? So today we have three esteemed panelists. We're still working on one who's having some technical difficulties. I always say this every time we have technical difficulties. Technology is wonderful until it doesn't work. And so Nyra Cooke is on her way. She's having some connection issues, but in the meantime, we have Dr. Freda Lewis-Hall and Dr. Essien with us, who are going to introduce themselves, and then we're going to get started with our questions. So I'm going to start with Dr. Freda Lewis-Hall.
Well, hello to all and welcome. I'm Freda Lewis-Hall. I'm a psychiatrist by background and training, and I've had, I think, a very interesting and exciting career from frontline healthcare in a healthcare manpower shortage area in the Virgin Islands to an academic post as the vice chairperson of the Department of Psychiatry at Howard University. And from there, I went into the pharmaceutical industry and worked across a number of companies, Eli Lilly, Bristol Myers Squibb, and finished off my time at Pfizer as the chief medical officer and then chief patient officer for a little over a decade. So very exciting. I'm working now in two areas specifically. The first is in health equity, and the second is in an area called purposing or repurposing, where we're looking at drugs that have been in development and haven't made it to patients, but may have purpose, and we just need to get the science around them and get them back on the road to patients. So those are kind of the areas that I'm focused in right now. And delighted to be with you to talk about health equity.
Dr. Essien.
Sure. Thank you so much again for the opportunity to join you all. I'm Utibe Essien. I'm an assistant professor at UCLA, so I'm on the faculty here, though what I say will be my personal thoughts, not my institution's, despite my background here. I'm a primary care doctor by training. And I also am a physician scientist. So I spend the majority of my time when I'm not seeing patients working on clinical research. And my research really is focused on this topic that we're discussing today, pharmacoequity, or improving equitable access to medications. And like Lydia so perfectly put it, from the drugs being tested and discovered in the labs all the way to our family members being able to safely stay on and continue on them at home. I've been studying a lot of cardiovascular diseases, from atrial fibrillation, which is one of the number one causes of stroke in the country, including diabetes, the anti-obesity medications, COVID, therapeutics. So really my work is expanded across the gamut of conditions that unfortunately impact communities of color more so than many other communities. And I'm really looking forward to our conversation around how we can think through the creative ways to keep improving access to these medications.
So wonderful. Thank you both so much for that introduction. I think you all both led me, particularly because you all have been and are practicing physicians. What are the barriers that our communities have, one, to being in clinical trials, and then two, having access to those medications once they come out of trials and are approved? And can you talk about why do you think these are? And if you have any solutions, it would be great, but I know that it's a complicated question.
I'll defer to Dr. Lewis Hall to start, of course.
Oh, okay. Well, lots. I mean, we could just go literally all day tomorrow and for the next month, literally talking about the barriers and how the system or the systematic issues kind of pile on to communities. And we are talking about communities of color in many instances, but it stacks, right? It's age, pediatric and the elderly, it's demographics of various kind, rural versus urban. So if you think about what the barriers are, they are multidimensional and dependent. So it depends. I'm sorry, I'm a storyteller. One of the experiences I had serving on the Patient-Centered Outcomes Research Institute board for about a decade was listening to patients. And what we realized very quickly is that we had a list of what we thought the barriers were, that we had experience with, that we had studied. And then when you talk to patients, sometimes it wasn't that at all that stood in their way. And so, about the barriers, one is, I'll call them systemic barriers that are compressed upon you, depending on where you live, work, play, pray. So those dynamics of where you are have a whole host of barriers that impact upon you. We saw that in COVID, for example, that certain people who worked in certain areas of employment had higher rates of infection, lower rates of early diagnosis, and so on and so forth. So that one, there are biases in our system. Specific biases. Go to an emergency room as an African American, chances are your pain level and the treatment for that pain is going to be less than it would for a white patient. And so those things happen across the spectrum every day. Inclusive research. I had an early experience with a patient. I was very full of myself in my white coat early in my career, and I was quoting articles. This happens in about 5% of patients, and this side effect, less than 2% of patients. And I just spilled all of that. And she very patiently waited, and at the end reached across the table and touched me on my hand and said, baby, if it happens to me, it's 100%. And so, the necessity to study across patient populations to understand what, if any, differences are there, so we could represent them and respond to them in the clinic. And then just another practical. My mother said, don't ever put only in front of time, toil, or money. And in many cases, those are the three things that stand between a patient or a family member and the care that they need. Where it is, how hard it is to take off work or to get there, that work, or how much it costs, however little or much. If you don't have it, it is a problem. So that's just a litany, and I'm sure that the other panelists will have lots to say about those and more.
Dr. Essien.
Sure, and just want to acknowledge that Nyra Cooke is on. So nice to see you. Looking forward to getting to you involved in the conversation and hear your intro as well. But I think Dr. Lewis Hall kind of shared it perfectly. And the things I always like to talk about are the ABCs of pharmacoequity or medication access, which is access, bias, and cost. So we already heard those. And I think when it comes to access, being really creative and thoughtful about how it's more than just having an insurance card or more than having a primary care doctor, that there are so many people in our communities who live way too far from a pharmacy to be able to get their medications, or don't have the opportunity to hop on a Zoom call like we are today to talk to their doctor with all the excitement around telemedicine to help improve access. So being really thoughtful around how we can innovate around access is important. Bias is a huge piece. We know the literature out there, and more importantly, the stories of so many family members who come in and out of the hospital and wonder why they didn't get the same care that their neighbors got, what the same type of conditions that they came in with. And so we have a lot of research to show that in particular Black women are less likely not just to get pain medicine, which a lot of people want to focus on, but even like cardiovascular procedures that help you get the right diagnoses and the right therapies. And then the cost, I think, is a huge, or not I think, the cost is a huge piece. We spend the most in our country on medications. We spent $370 billion last year on prescriptions. Or million, excuse me, and that's just not affordable and available to people in our communities, especially given the huge wealth disparities we have here in the US. So unless we address these ABCs, we're going to be a long way from getting equitable medication access. And I hope that we can, again, come together as a team to talk to what you mentioned, Lydia, about the solutions to be able to fix some of these issues.
So Nyra, thank you. I know you were having technical difficulties. It's okay. It happens almost every webinar. So I was gonna, my point was to get to you, let you introduce yourself and talk about this first question, which is, what are the barriers to access for communities we care about to medication? So please, Nyra, introduce yourself.
Thank you, and my apologies for the technical issues, but I'm really happy to be here with you guys today. And hi to my fellow panelists as well. So to introduce myself, my name is Nyra Cooke, and my current role at Takeda Pharmaceuticals is in our patient access team that sits within our patient access and patient and market access team. My apologies. And my role is to lead one of our therapeutic area teams that help patients to find resources to help with accessing their medication. And I know you guys touched on a lot of examples already. So to probably hit on something that I didn't hear in the short time that I joined is probably more around access to quality education, about resources that are available, and also just about the healthcare and condition themselves, right? The less informed you are, the less likely you are to treat as well. So that's something I think that I didn't hear from what I heard so far.
Fantastic. And I want to talk a little bit to you, Dr. Essien, because you have coined this term called pharmacoepi, and I wanted you to just talk pharmacoequity, sorry. And I wanted you to talk a little bit more about why you thought that a term needed to be coined. What does it mean? What's your interest in it? And why is it important for us to focus on particular medications and access to medications for the communities that we serve?
Yeah, thanks for that. And I love how Dr. Lewis Hall kind of mentioned her experience putting on her white coat and explaining to patients about the risks of medications. I think that's the same way that I came into my medical training, where I'd seen the inequities growing up in Brooklyn, the Bronx, and Queens, and New York City, all throughout my training as an undergrad, working in emergency departments. Going to medical school in the Bronx and seeing how people who went to the community hospital or public hospital versus the private med school hospital were treated very differently. And I figured by the time I got to residency, I had these tools. I was finally going to be this like social justice warrior for my patients, and realized like there are so many more issues beyond what I could do to get people the right treatment. Those social determinants that I think Dr. Lewis Hall was kind of alluding to earlier. And so to spend a lot of time focusing on those, thinking about how we can improve housing and food insecurity and immigration, all these issues that impact our patients and families' health. But once we address those, and once we work with our community members to address those, the fact of the matter is people still come into our clinics, they still come to our hospitals, and they walk away without appropriate medications. And we saw that play out so vividly during the pandemic, which is right around when we coined this term pharmacoequity, that the minoritized communities and populations who were at highest risk of dying and of getting infected, when these new, exciting, incredible medications and vaccines came out, they were also ended up being at the lowest risk of getting treated. And so that juxtaposition, I think, is really what brought about this term, which is basically just making sure that every patient, regardless of race, ethnicity, social status, has the right and equitable opportunity to get the most available, appropriate, guideline recommended medications for them. And that's really where the term came about. It's kind of formed through the pandemic, but realizing that whether we think about COVID in 2020 or we think about the HIV epidemic in the early 1990s, the same stories play out. When the new medications became available to treat people with HIV to prevent bad pneumonias from happening, it was the same Black populations who are at highest risk of getting infected who are the least likely to get these medications. So this is something that we've seen sadly throughout our history in this country. And I think and I hope that we can kind of framing it and really focusing our attention on it can help us figure it out so that in the next 30 years, we don't have the same story play out.
Thank you so much for that explanation. And I get exactly where it came from. So I want to go to the conversation that you said you want to talk to, because all of you are these wonderful minds and experts in this field. So how do we solve this problem? What are some of the policy, practice, I think Nyra made a good point, educational tools that we need to give to our communities to help them to be able to access these medications that are so needed for them? You know, a perfect example is kind of funny, but it's like, you know, right now we have the Ozempic craze, but there's people who have diabetes who actually need Ozempic, and I can't, or whatever the GLP-1 you take, and can't get access to it. So, you know, that's a problem, because it's not just about, you know, losing weight. It's about people who actually need this medication to live. And, you know, it's becoming so expensive that they can't access it. And so how do we help with that? How do we reduce some of the barriers? What are the things that we can do on policy, practice, and educational levels to start to combat these barriers?
Can I jump in and add one thing before the education? I'm all about education and believe it's really important. One of the things that I think we need to do is educate ourselves. We're doing it now in this way, but my experience has been when you're actually sitting with people and asking them what stands between you and your medicine, or what stands between you and the right diagnosis, or what stands between you and your seeking treatment. I'm not sure that we have really collected enough information in order to uniquely address the issues of families of our community. And so I would love to start with a listening session, you know, spending time in the community saying, what do you need to know? Who do you need to know it from? What process should we use to provide this to you? So kind of educate ourselves about the education process. And then I do think it is really, really pounding the pavement with education. And can I give an example that I thought was quite stunning? We were looking at nerve pain and nerve damage, and realized that damage that's caused by diabetes was, if you looked at who was treated, was very low in the Latino community and the African American community, which didn't make sense because the rates of diabetes are so high. So we actually went back and asked, you know, let's survey you with these survey tools and see if we can find people who have this disease. We didn't find it. And so finally, somebody raised their hand and said, maybe we're asking the wrong questions of this particular community. And we went back and said, do this. If you were telling your cousin your symptoms and your experiences, tell us what you would tell them. Then we went back with that and asked people that we didn't know whether or not they had the disease, answer these questions for us. Guess what happened? The number of patients that we discovered soared because we were using their words to ask them the questions that we needed them to answer in order to correctly diagnose them. So I think it's education both ways, educating ourselves about what's actually needed by each and every community and each group that we're trying to serve, and then giving them what giving them what they need or what they say they need or demonstrate that they need.
Fantastic. Nyra, I see you have yourself off mute.
Yeah, no, I think, Freda, you make an excellent point. And I think so much of what we're talking about, to your earlier point too, there's no one quick fix for this. This is a pretty big and multidimensional issue that's definitely going to take a lot of us to sort of put our heads together and come up with solutions. And there's no one unique solutions that's going to be perfect for everything, right? So certainly we think that partnerships is an important part of it, which is part of the reason why we've partnered with the National Urban League to make sure that we're understanding the unique needs of the communities that we're supporting and really having folks that are embedded into communities and working with community leaders to make sure that we're understanding the unique needs of the community members that they support, right? But in terms of programs that are available, Lydia, I know you asked a little bit about that. There's a lot, but if people don't know about them, they're not going to be able to access them, right? And that's the other part of it too, is making sure that there's high level of awareness of the programs that are available. So everything from manufacturer programs, Takeda has a number of these as well, whether it's charitable access programs, early access programs for pre-approval medications, as well as patient assistance programs that could provide both financial assistance as well as education for patients that are eligible for that, right? And certainly there's a number of patient organizations as well that can be very helpful in even helping with some of those ancillary costs like transportation. I think I heard that folks were talking about before, which can be so critical. I mean, I remember even just from personal experience and having, my parents both being diagnosed with cancer, just the American Cancer Society was phenomenal in terms of helping us with resources and even, providing transportation to appointments and things like that. So when I think about education, it's not just about the condition or the medications themselves. It's really just about the resources that are potentially available as well.
Yeah, and thank you, Lydia. I love that you mentioned like policies and programs, because I think a lot of this conversation around access ends up focusing on the people and that P. And so the patient, the physician, pharmacist, the nurse practitioner or PA, and that relationship, which is critical. We know that there's different time spent with certain groups of patients, including minority patients, who end up getting different care because of that. We know that sometimes people are kind of seen as a difficult patient or a difficult family member if they advocate for themselves, even though we know how much an important patient advocacy is. But I think if we focus solely on that, we end up missing the bigger picture, which are the practice and policy changes that we need to make. I think one big policy change that came out over the past year or past couple of years now is the Inflation Reduction Act, which for Medicare beneficiaries, so older adults age 65 and older, or those with end-stage kidney disease, that they can actually have affordable access to a number of medications. And right now that list is at 10, hopefully expected to expand. And these are medications for conditions that are incredibly common in our communities. So atrial fibrillation, as I mentioned earlier, diabetes, a number of other cardiovascular diseases. And I think that policy, which was really important and came through from the current administration, is really going to impact the lives of millions of people and their family members, not just the patients, but of course their family members who are helping to take care of them. And those are the type of policies that I think we need to get creative with. How can we really address this issue of cost, which I know we have bigger or broader issues around trust in medications. Like, do we actually know enough about the medications that we need? But when we have the information, when we have the tools, when we have that app that tells us what this condition is and that these new therapies are available, and we turn our computer to the patient and tell them you're going to have to pay $1,000 a month for the next several years to treat this condition, how are people actually going to be able to do that? And I think once we address the bigger policies of really helping to address the cost, we can finally have people really trust that this is worth it. This is actually something that's worth my time and money.
Thank you, Dr. Essien. I appreciate that. And you actually led me right into my next question. Besides the trust, like there's this trust component, I do want to spend a little bit of time talking about clinical trials, why they're so important, why getting diverse communities into trials are important, but not only for the drug development, but also for the communities themselves. I think sometimes people do not realize that experimental or drugs that are going through trials can benefit those patients, and that it could be something that is a therapeutic that works for them. And I think sometimes we see clinical trials as just the test, right? You're just testing me to see if this drug works, but it actually has some therapeutic benefit. So Dr. Lewis Hall, I want you to talk about EQB Med a little bit and why is it so important, and why did you kind of come together with a bunch of folks to form this collaborative to increase diversity in clinical trials. And then I want to ask the other two members about clinical trials in their respective areas. But I want to start with Dr. Lewis Hall.
Yeah, well, thank you for that. And I am really excited about the work at EQB Med and the many partners that we have as a part of that work, and for pharma's kind of enthusiasm in getting this work going and participating. So the idea is we've been working on this. This is not a new thing, right? That clinical trial diversity is lacking. And these are not the first opportunities for us to try to make a change. So several things are happening. The first is we realized that you can't do it alone. A lot of the work that was happening in silos. The university might have an effort, a company is working on something, a part of the ecosystem decided it was an effort to participate in, but to actually integrate the work that we were doing from beginning to end, to understand what the barriers are and then to address them, has become the work of this project that we're working on. And the members are from industry, from academia, from all over the country in their representation, and from community organization, faith-based, educational, et cetera, et cetera. And the idea is to, one, identify very specifically barriers, including what policies, procedures, and activities happen in the conduct of clinical trials operationally that stand between patients, diverse patients, and actually participating. And that includes trust. And I'm going to come back to that in a second. But the other thing that we're doing is a learning phase. So we're asking ourselves, can we set up sites where people are that are accessible to them? Can we use technologies and make those available? And can we do other things that are novel and innovative to make trial participation accessible? One, then can we partner in communities and at those sites and help educate the community about the importance of participation for themselves, Lydia, to your point, that if I have a rare cancer or a rare disease and someone's doing a clinical trial, I might have access to something that would work uniquely for my issue that may not be yet available. But also, many people who participate in clinical trials say, if I have breast cancer and can be in a breast cancer trial, if my daughter gets it, I want to make sure that she has the best, newest thing possible. So I'm doing it for our future. And so those are the kinds of things that we're working on with the community, with individual patient groups and organizations, and with academic institutions and companies, all coming together to say, what does it take at a site like this, with a population that we're serving of this age, of this other demographic, what are the challenges of setting up a site, getting people involved, integrating and involving the community, and actually making it happen. And if we have these archetypes and we can say, okay, type A, we need to do these things, and then in this a little bit differently, then we're using this learning phase to say, okay, now we understand this much better, we can scale.
And I just realized I used the acronym. I did exactly what I told people not to do. Is equitable breakthrough in medicine development. And full disclosure, I am on the National Advisory Board as a member from the National Urban League. We are one of the community members that are supporting this effort to try to increase diversity in clinical trials. So I want to give that full disclosure.
Thank you. And I also want to add, one of the other things about the clinical trials is people think that many people believe that the only way to participate is to be a patient that's participating in the trial. I think there's an important thing. If this is an opportunity for us to say, you know what, we need some questions answered about lupus and sarcoidosis and maternal mortality, and we can go on and on. These are the questions we as a community want answered. Second, there are ways to actively participate on advisory committees, on review boards that actually look at protocols and help modify them and then approve them for participation. So there are many ways, in addition to being a patient participant in a clinical trial, to help make the diversity of clinical trials work.
Thank you, Dr. Lewis-Hall. That's a wonderful point, because it's about making sure that the communities we care about have access in many different ways. And so by reviewing a protocol and saying something like, this is not an accessible way for our community to get to this clinical trial, helps the clinical trial designers and the folks who are doing it be able to make sure that everyone has access. So I love that point, that clinical trials are not just about the patient taking the medication. It's about everything around it to help the success of the trial. If the therapeutic is effective, go through and get access. Dr. Essien, in your work with patients, have you ever referred one to a clinical trial, and what were their reactions, and how did you help them, if possible, get over it? Or maybe they were excited. I don't know anybody who's excited to be in a clinical trial, but I could be wrong.
No, I think what was mentioned is that clinical trials are a really important way, and I think maybe you mentioned this, Lydia, to get access to new medications. There are a lot of difficult to treat cancers, difficult to treat other kind of rheumatologic diseases that just don't have a lot of medications or options out there. And it is these kind of phase 3 or later phase clinical trials where medications are being tested in humans that really are the only option for a number of patients. And so I think you asked the question, like, my job as a primary care doctor is to help refer patients to specialists. And that is a really important gap that we don't think about a lot in terms of accessing clinical trials, is that the kind of gatekeeping through some insurance companies or through some health system kind of policies, where primary care doctors have to get patients to the specialist, and the challenges in getting the specialist, the lack of trust of specialists, ends up preventing a number of patients from even having access to those clinical trials. So I think that's an important gap we need to pay more attention to. The physical access of having to show up to another appointment, to park in the expensive parking lots at the clinic if you have a vehicle, or make your way over there. The time off of work and time away from childcare, all these kind of resource intensivity of being in a trial, I think are also features to think about. And just a couple of years ago, I think it was now, Medicaid is actually helping to provide some financial assistance for patients to be enrolled and participate in trials. So again, we have like really cool tools to get creative to help people address some of these systemic structural barriers, so that it really is just a conversation of, is this the right option, an opportunity for me? And if so, I can go after it and not have to worry about all these other pieces.
Nyra, can I ask you a question around, because you're coming from it from a little bit of a different angle, because you work, at a pharmaceutical, company. How do you all think about clinical trials, and then how that leads to access to the patients that you're trying to reach?
Yeah, no, so great question. And I think for us, this is incredibly important, right? So, and recognizing that we play a critical part in how diverse our clinical trials are. So for one thing, Takeda is committed to having 100% of our clinical trials have diversity and action plans built into them. So we're holding ourselves accountable to making sure that our clinical trials are diverse. And we're doing everything from, making sure that communities are educated on the very, basics, like what is a clinical trial. I think there's often a lot of misperceptions about what a clinical trial even is. So that information is really important. And to share something that's more of even a personal story, like I received an email probably a few months after I had my twins, and it was asking if I could join a clinical trial. And I had my own biases, and I work for a pharmaceutical company. I immediately looked at the email and I'm like, absolutely not. And then I have to take a step back and say, you're part of the problem. The information that you could provide to this is critical, and there's a reason why they're asking you. You're probably one of the minorities that is very, difficult for them to get in touch with to participate. So I had to take a step back and even, check myself. And I, did sign up for it. And lo and behold, it didn't actually even require me to drive anywhere. They were using my already available medical records that are in the doctor's offices. And I just had to get on the phone and talk to someone for a few minutes and answer some questions. So I think it is important to just inform people, because I think sometimes people have set, things in their mind of what a clinical trial is and what it could potentially look like. And it could look very different depending on the disease, the therapeutic areas, or what they're looking to study. I think awareness is also incredibly important, right? If people in the community don't know that something's available, then they don't know that it's available for them to take part in it. So part of the work that Takeda does is making sure that communities are aware of the clinical trials that are happening nearby or locally. And then in terms of the clinical trial recruitment, making sure that there are, that we're having our clinical trials in communities where we're seeing the representation that we want to see in a clinical trial. So if you're not in an area where the population itself is diverse, by nature of that, you're not going to have a diverse clinical trial, right? So putting all of those things in place from a process standpoint is something that we're holding ourselves accountable to making sure that we're having a more diverse clinical trial.
So interestingly enough, in one of the questions in our question and answer, I've been holding them, but this one is applicable, so I want to say it. So one of our audience members asked, where is a good place to start in searching for clinical trials to apply to?
Great question. So there is a website that's a government website. I believe it's clinicaltrials.gov, where you can sort of search by different therapeutic areas. I would say, talking to health professionals is also really, important. Depending on what your treatment plan, they might be able to direct you to clinical trials that are available. And doing sort of like the research online, it can be really helpful to sort of get a sense for what's available.
And if you have a specific disease, there are sometimes reference sites like the American Cancer Society, American Heart Association, et cetera, that, right, so disease-focused or disease-specific organizations often have either a website that will, allow you to go straight to it, or it will have experts within the organization that can refer you to centers in your area that might be helpful.
Yeah, and I think the clinical sites as well. So your local institute, health system that you may be being a part of, especially those that are with academic medical centers. Again, not everyone has access to a large academic medical center like this one that I'm working at, but I think the more and more research programs are being led and conducted out of community-based clinics and federally qualified health centers and other kind of safety net settings. So our hope is that we'll continue to make those available for all patients. So like I think Nyra mentioned that having your health provider asking them, inquiring what are the options available in your setting will be helpful too.
I think that's a really good point. I do want to say, even if your provider doesn't know of a trial that's available, just asking the question might trigger in them, hey, let me look to see, because they may know better how to find one for you, but it also helps them to be like, oh, this person's interested. Let me see what I can do, who I can talk to that may have a trial. So I think also asking the question is really important, because there is an assumption that, you know, kind of, I love Nyra's story, because kind of like we all are kind of like, no, I'm not doing this. You know, same thing. My dad, they, you know, wanted him to do a trial. And at first we all were against it. We were like, no. And then, you know, we sat back, and my sister's a physician, right? And we sat back and thought about it, and we're like, well, maybe he should do this, because of what I think Dr. Lewis Hall said about it may not be for him, he's fine, but for the children, the grandchildren, the information that can be learned from this trial can help generations going forward. And so, but it took us a minute, right? I got to say, it took all of us a minute to say, they're just trying to experiment on my dad, right? And so, you know, and we do have legacies from, you know, a history, you know, Henrietta Lacks, you know, Tuskegee, other ones. A lot of folks bring them up, but they bring them up for a reason, because we have not had the best experiences, including Native populations have had worse experiences. I don't want to compare experiences, but the same thing has happened in Native populations where people have taken their cell lines and doing experiments that they didn't know. And so, but, you know, the more questions we ask, the more educated we are, the more do we not get in that situation, but also the more that we can get the benefit from it. So I think it's important for us to talk through kind of why clinical trials are so important for folks to be part of, and then how to safely be part of one to the benefit of our communities. So thank you for that, because I think it's really important. Go ahead, Dr. Freda.
I was going to say, I think there's also an opportunity, our activism. So back in the 90s, when women in clinical trials was a really big issue, women started demanding so the education process was not, please, please, please participate. We were like, do you realize that these things are not known about women, and these misperceptions pull through in the clinic, and women became incensed by that and became advocates for participation in clinical trials. And I would love for us to get there as a community to say, not only am I willing to participate, but I'm demanding an opportunity to participate, to have my community represented in these trials, because it's important. And I think that education is going to be key. You know, we're beginning to put the processes in place to open the doors for access. And to your these wonderful examples of kind of having to be turned around on participating becomes really important. So hopefully we'll be able to get the enthusiasm, but also to talk about how important it is for us collectively to make this happen.
Wonderful. Thank you. Before I get to questions, we got about 12 minutes left. I do want to get us to, why is it so important for this connection between clinical trials, access to medication, and the health outcomes of our communities? Can we talk a little bit about why those three things are along the development spectrum are really important in terms of getting medication in people's hands? Anybody can take it.
I'd love to start with that, because I think that's a segue to the point that I was going to make after Dr. Lewis Hall's comment, which is, you know, we build up the trust in these medications. We start demanding to be participating in trials, people getting involved. We have diversity representing the national population. And then this amazing new therapy comes out, and it's $50,000 a year, or 70,000, or whatever the number is. And all these amazing, incredible family members and community members who participate in the trials can't actually get the therapy. And I think that is one of my worries in this kind of push for recruitment and diverse recruitment, is that we spend a lot of effort, a lot of intentional effort, we're finally getting people involved in this work to be the same people who aren't even going to be able to take those medications. And so I think we have to focus on the path, the continuum of pharmacoequity. So building the diversity in the therapies, in the trials, but also thinking about that equitable implementation or the equitable diffusion of these medications, so that when that FDA approval comes out based on the hard, for lack of a better word, on the backs of minority populations who now are going to participate, they're not going to end up being the people who don't have access to those therapies. Because that's what this is all about. Like you mentioned, Lydia, it's about improving health outcomes. We're not just trying to make more money for pharmaceutical companies. We're not trying to just have it so that stocks rise. We're trying to make sure that these huge disparities that especially exist in minority groups in this country are narrow, that we're not dying earlier than non-minority populations, that we're not having higher rates of prenatal death or maternal deaths or other related deaths in our country, that we're actually able to live these long, sustained, healthy lives. And that's why I think we want to improve access to medications, not just to build incredible scientific discovery, to win more Nobel Prizes, et cetera. So that is that deep connection between clinical trials, actually getting meds in hands, and hopefully being able to improve health outcomes.
There's also, I think that is so true, creating this continuum and understanding that it isn't just getting the data right, it's getting the access right as well. But there's a really good clinical reason for us to have the data and the information as well. So in some populations, the existence of an enzyme is higher. That enzyme degrades the medication that someone's taking, which means they may need a higher dose, or it doesn't degrade it as fast. They may need a lower dose so that they can experience, kind of moderate side effects. So you won't know that early enough to really understand whether or not I should be dosed the same as the person sitting next to me, or whether or not I require the investigation of whether or not I would have that enzyme and therefore would need a different dose. And also, we're beginning to understand more about diseases, right? Think 20 years ago when we were talking about cancer as if it was one disease, right? The fight against it. Now we realize it's 1,000 diseases. And the more we know about who is susceptible to one, how it, which mutations in a cell lead to the cancer in one group, maybe over another, depending on where they live or what they eat or what their genetics are, et cetera. So these are things that we can begin to tease apart if we have this fulsome participation in clinical trials. Again, it's age, it's ethnicity, it's race, it's all kinds of, all kinds of other things that the more we know, the better we can then say, okay, Freda, here's what we understand about you. And this is therefore what we would prescribe for you. And we're going to get the dose right. We're going to be watching for the right side effects so that we can manage them and so on and so forth. So I think there's a really important clinical reason for us to understand populations that are then going to be exposed to the medications.
Yeah, and you guys hit the nail on the head. You said it quite perfectly. And I think in addition to sort of like the health outcomes and things like decreased quality of life in certain populations as well is something that can certainly be affected by making sure that everyone has the appropriate access to care. There's also an increased cost to the healthcare system, right? And I think people sometimes have this misperception that untreated saves the system money, but it actually increases the cost in the overall healthcare system. And then also the more sort of already underrepresented populations have least access, it only further widens the social inequality. So it only widens that gap, and it becomes just another element that sets people even further apart. So it's just really important for us a really important topic for us to continue to think of ways to solution.
Fantastic. Thank you all so much. I mean, just the breadth of knowledge and experience and solutions that are on this panel is amazing. And I thank you so much for being part of this. I do want to get to a couple of questions because there actually are a few questions in the chat. And so I think I answered one already, so that one is done. We answered on how to get access to clinical trials. I think this is a little bit more directed at you, Nyra. One of our participants said, I love Takeda's Help at Hand Patient Assistance Program for, I can't pronounce the drug name, Vivacin, I think, that ended when a generic was released. And it said something like it really helped a lot. So, not to completely put you on the spot, but like what happens in these situations when people had patient assistance programs and then it goes generic, and then people may, going to Dr. Essien's point, may still not be able to afford the medication? What are ways that we can help patients get access to what they need, even in these situations? When we understand things have to go generic, usually they're cheaper, but sometimes they're not that much cheaper. And so how do we still help patients get access in those situations?
Yeah, and we certainly still can. And it is on the spot because I don't know specifically if anything has changed with that specific program, since it's not one of the ones that I'm as close to. But certainly I would encourage that person to still reach out just to see if there is any programs that are available to help support that. And the same goes for any medication, right? Whether it is another option and not just a Takeda therapy, I would say I would really encourage people to sort of research the resources that are potentially available for it, because it is about getting the right medication that people need to help support their health outcomes.
Excellent. There's also a question in the chat, I think, from one of our community health workers who works in one of our Nebraska affiliates, about this issue of off-market labeling, right? So, the one I mentioned before, the Wegovy, Ozempic example of people using it primarily for weight loss, even though it is a drug that has been developed for diabetes. How do we help? I'm going to kind of frame the question a little different. I hope the person gives me that kind of freedom. How do we make sure that people who need the drug for diabetes reasons can still access them, but also those who are using them for weight loss reasons can use them in the way they can without having the supply chain issues or access issues that we're seeing start to pop up, particularly with Ozempic? Any thoughts? I know we don't have full information, because if you had full answers, we'd solve this. But just any thoughts on how do we help with that, particularly for practicing physicians who are prescribing, right?
It's an issue that we see. Like, I get texts from my colleagues in primary care literally every day about this. This is not going anywhere anytime soon. And of course, this is the current moment with these medications, but there's going to be another medication that's really important, that's really helpful in life and transformative for a lot of people that we see this challenge with. And so again, we have to think about that continuum, like having an equitable drug manufacturing system in our country is apparently going to be helpful to addressing equity issues as well, right? And that's probably not something that many of us in the health equity space are thinking about. But if we are telling patients, contact your doctor, get the right treatment, you now trust again that we have a medication for you, you made it through all these hoops, you got the financial assistance support that you needed, and you go to the pharmacy and they don't have the therapy. Like, how's that helping to support trust, right? And so we have to continue to work with our policymakers, who are the ones helping to address some of these issues, the drug manufacturers who are helping to address some of these issues, to really be thoughtful about making sure that the medications that really are transformative for people are available. I Obviously, we need to think about the people who don't need to be on certain medications, who may also be impacting challenges around drug shortages. But I think this class of medication obviously is really important for a lot of communities, making sure that's available for those who have traditionally been underserved and had poor access to these, I think should be the priority for sure.
Fantastic. Well, I'm going to respect people's time, and we only have 1 minute, but I do want each of our panelists to leave us with some final thoughts for our audience, or something that you wanted to convey that maybe we didn't get through to the questions. I do want to make sure that I give everybody a chance for final thoughts. So I'm going to start with Dr. Freda Lewis-Hall for final thoughts.
So this is an all hands on deck opportunity for us to solve. And we have so many barriers and so many opportunities. So I'm encouraging no matter your area of participation, whether you're a patient, whether you're a policymaker, whether you're an advocate, that you begin to look at this from a systematic standpoint, understand the barriers, and then if each of us, with our special interest, talent, and opportunity, tackles one of these, and we do it in concert, hopefully we'll get these complex issues solved for patients and people in need.
Nyra.
Yeah, no, I would say a few things. Well, first of all, thank you, because this has been a great discussion. But to Freda's point, there's definitely an opportunity to make sure that it's all hands on deck to solve for this. And it starts with us as individuals, making sure that we're well informed. It also starts with us as individuals making sure that we're informed on policies that are, going through, and holding our government officials, accountable to making sure that the right policy is in place to ensure that there's appropriate access to medications. And then also too, the only other thing I would leave for people to think about for themselves and for their family members is advocating for yourself as well, and not being afraid to ask questions and do your own research. So it means a lot to join a family member to a doctor's appointment so that there's a second set of eyes and ears listening to the conversation. But don't be afraid to ask questions. Your health is vital and incredibly important, and it's okay to continue to push and get the care that you need.
Fantastic. Thank you. Dr. Essien, last words.
Yeah, thank you. So similarly grateful to be here. I think we'll just leave with those ABCs of pharmacoequity, like if we can improve access, reduce bias, and lower costs, I think we can actually really get us closer to equitable medication access. The last thing I'll make that hasn't been raised yet is that the majority of our health system does not look like what's represented on this Zoom screen right now, and that there are, speaking of policies going into place that are trying to make that even less likely. And so again, speaking of advocacy, the more we can do to ensure that your family member's doctor, the scientist and researcher, the VP at a large pharmaceutical company actually represents our communities, the more we can actually address these issues that not everyone is prioritizing.
Well, I want to thank my panelists so much for being here, for providing your insight. I also want to thank Cytokinetics, who actually helped us sponsor this webinar so that we can have these brilliant minds here to talk about this issue and to really make sure that we improve access and diversity to medications in our communities. Thank you all so much for taking the extra 2 minutes because we're a little over, but I think it was an important conversation. I want to make sure everybody had their final words. So have a wonderful day, everybody. We will see you next month for another health equity webinar series, and this will be posted on YouTube in a couple of weeks if anybody missed anything. So have a great day and goodbye. Thank you, everyone.
Bye. Thank you.
Thank you.